Hello everybody and welcome back to Emergency Medicine Quest. In this video we will be discussing about oral medicine. Make sure to like, share and subscribe to the channel for more such content. Let's start by brushing some of our anatomy. So we have 20 deciduous or primary teeth and we have 32 permanent or secondary teeth. The part of the teeth that is visible above the gingival margins or above the margins of the gum is the crown, which is what we normally see, whereas the lower portion of it is the root. The crown of the tooth has got three layers inside. So we have got enamel, we have got dentin, and we have got the pulp cavity. The enamel is the only part of the tooth that is visible, and it is a hard coating that has a protective function. Dentin is the intermediate layer and it is mostly yellow in color. I'll just paint this part yellow. Now it has got a lot of microtubules in it that act like a cushion, especially when we are chewing. If dentin gets exposed because of any reason, then the patient is going to have sensitivity and pain. The deepest part is the pulp that actually carries nerves and blood vessels. We have, as we discussed, 20 deciduous teeth. The first tooth to erupt, which happens at 6 months of age, is a lower central incisor. And we have got 32 permanent set of teeth. So from the center we have central incisor, lateral incisor, canines, two premolars and three molars. Premolars are also called bicuspids and molars are also called tricuspids. Moving on to the disorders. So the first disorder to discuss is tooth decays or dental caries, which basically happens because the teeth breaks down due to bacteria. It is also the most common source of odontogenic pain, and patient can come with a very variable history of there being a sudden or gradual onset, sharp pain. Some will complain of dull pain, some will complain of throbbing pain, and in most cases the pain of tooth decay can be localized to one single tooth. While we are looking for dental caries, remember to look at adjacent structures as well, like oral cavity, gingiva, and surrounding structures like throat, neck, and sinuses. There are no labs or imaging that is required from us in the ED, and management wise the only goal of treatment in tooth decay is pain management. Aside from pain management, there can be a referral to dentist for definitive care. So in terms of pain management, what are the things that we can do? Definitely we can discharge the patient on NSAID, so we can give ibuprofen 400 to 600 milligrams to be taken every 6 to 8 hours. But if the pain is very severe, then local anesthetic can also be injected in the nearby gum to provide some temporary relief. And inferior alveolar nerve block can be done, especially when multiple lower teeth are affected on one side. Opioid analgesics should not be prescribed for long-standing dental problems. Moving on to disorders of gingiva and periodontium. So periodontium's purpose is to hold the teeth in place and protect the root from bacteria. So what is periodontium is basically the attachment apparatus plus the gums. Okay. So the disorders can be characterized as gingivitis, pericoronitis and gingival hyperplasia. Gingivitis or periodontitis is basically the inflammation of the surrounding structures of the teeth. So that in that we have gingiva, we have alveolar bone, we have cementum, we have periodontal ligament. Most of the time it is polymicrobial, but particularly Fusobacterium is implicated in most of these cases. Now these cases can vary from being quite simple to complicated with diseases like necrotizing gingivitis, and if the infection further involves the tonsils and the pharynx, then we call it the Vincent's angina. The most severe form of periodontitis is actually called noma, which involves the entire mouth and is very fatal. Pericoronitis is basically the inflammation of gingiva and the surrounding tissue. Most commonly, this is seen when people are having their wisdom tooth eruption and a flap of gum overlying these teeth becomes the source of pain and swelling. So that flap of gum that overlies these teeth is known as operculum. But other than wisdom tooth, we can also see it in conditions where the tooth is impacted. Finally, we have gingival hyperplasia, in which basically there is an overgrowth of gum tissue around the teeth. It can occur due to poor hygiene and dental plaques, but it can most commonly occur due to drug reactions. So some of the drugs that are implicated, so anticonvulsant, in particular the anticonvulsant that is associated with this is phenytoin and immunosuppressants. So again, the drug that falls under this category and causes this condition is cyclosporine, but other than that, calcium channel blockers can also cause hyperplasia. If we talk regarding the way these diseases present, so gingivitis or periodontitis will basically present with swollen or tender gingiva. There will be bleeding if you touch the gum, and there will definitely be bad smelling mouth. If the condition is very severe, then in those cases we can even see patients presenting with fever and malaise. Now normally what do we see is that our interdental papillae, which is basically this area, is pointed out. But if there is going to be a necrotizing disease, then it becomes blunted and punched out or even ulcerated. So how do we diagnose a necrotizing periodontal disease is with papillary necrosis. We will see gum bleeds, and obviously there is going to be a lot of pain. Normally these conditions do not require any lab investigations unless we are thinking about patients with HIV, or if there is some poorly controlled diabetes, or if they are on immunosuppressive therapy. Regarding management wise, so gingivitis listens to good oral hygiene, and that is what we should ask the patient to focus on. We can aid this process by giving them chlorhexidine, which is going to be in dosage of 0.12 to 0.2% or 3% hydrogen peroxide, but chlorhexidine is the preferred agent for a mouth rinse. We can give pain control. So once again, we can give NSAIDs like ibuprofen or paracetamol to relieve the pain. For pericoronitis, they can also receive these mouth rinses. Systemic antibiotics in pericoronitis should be reserved. The case is very severe. So in that case, we are going to give those patients penicillin 500. And if they are allergic to penicillin, then we can give them clindamycin. So regarding disposition, all these three categories of diseases can be discharged and will require dental follow-up. For gingivitis, periodontitis, we can give 1 to 2 weeks of follow-up, but if they are coming with necrotizing gingivitis or they are coming with any systemic sign, then we have to get them to see a dentist within 24 to 48 hours. Moving on to disorders involving dental procedures. So, the most common dental procedures that we know of is fillings, crowns, root canals, and extractions. What is a filling? Filling is just a cover of the caries that protects the tooth from undergoing further decay. Crowns or caps basically cover the part of the tooth that is exposed above the gingiva. Root canal basically involves opening the pulp chamber to remove the pulp tissue and to sterilize the canal and then sealing it again. Extractions are basically removal of the entire tooth, especially those that are non-salvageable. So if a filling or a crown gets dislodged, the patient can come with very sensitive pulp and they will complain of severe dental pain. Similarly, if a patient has recently underwent a root canal, they can come with a pulp that has been irritated because of the residual gas bubbles. So that is going to cause them, a lot of pain. And one particular thing that patient can come complaining of is alveolar osteitis. What basically happens is after a tooth gets extracted, there should be in a normal person an adherent clot. If this clot gets dislodged, which we typically see happening after 3 to 5 days of the extraction, then the area is going to appear like this, and we also call this as a dry socket. So normally when patients come with complaints after a dental procedure, normally in their history they are going to give a history of some recent dental procedure that is going to point us to that direction. Alveolar osteitis, as I said, presents typically 3 to 4 days after an extraction. They will come with severe dull pain at the site, and sometimes they can have halitosis or just a very foul taste in the mouth. Sometimes they will come and give the history that they were sucking through a straw or they were picking on with a toothpick that caused the clot to get dislodged. Certain patients will also come with continued bleeding after the dental procedure, and in those cases it is worth asking if they have an extensive history of coagulopathies or if they're on any anticoagulants. Diagnostic testing wise, again, there is not much we can do, but if somebody is coming with excessive bleeding, for instance, then it might be worthy to check their INR if they are on any anticoagulants. Management wise, what we can do is if they come complaining with sensitivity and pain and we see that the pulp is exposed, then what we can do is apply calcium hydroxide. Basically, this is going to cover the exposed area and will provide them symptomatic relief, and this should suffice normally. But in case they are still complaining of pain, we can prescribe them NSAIDs. In some cases, they might complain of a very severe pain that might not be resolved with NSAIDs, and in such people, we can give opioids, but it has to be a very short course of opioids, generally 2 to 3 days, whereby we can give oxycodone 5 milligrams. Remember, alveolar osteitis, you can manage the pain in the ED, but it requires prompt referral to the dentist. If for some reason there is an anticipation that the follow-up is going to be delayed, then we can give them a nerve block. And if we notice that the area where there was supposed to be an adherent clot, but there is just some residual clotting, it should not be curated and it should not be removed. Some practice also suggests the use of medicated iodoform gauze with an anesthetic called eugenol. So basically this gauze can be placed in the cavity and then the referring dentist can see and change it in 24 to 48 hours. If a patient is coming with extraction site bleeding, as always we need to have a look at their ABCs followed by managing the bleed with direct pressure, or we can put a gauze that is soaked in tranexamic acid. But if this is not working out, then what we can do is perform a supraperiosteal nerve block using lidocaine and epinephrine. We know that epinephrine is going to decrease the blood supply to the area and hopefully should stop the bleeding.